Welcome to the Prescription Drug Abuse and Misuse Grand Rounds. This is our seventh Grand Rounds that is basically sponsored by the National Institute on Drug Abuse grant that we have here to work on prescription drug abuse prevention. That project has many of the co-investigators and project staff are here today. If you're affiliated with DIDARP, just kind of raise your hand for a second. And that's that group. And we also have some pharmacists in the back, is that right?
Students.
Students?
Yes.
Okay, pharmacy students. And we also have Dr. Woodside.
Family medicine.
For medicine, family medicine. And so that's who your audience is today.
Excellent.
We are really excited to be able to introduce you to Fred Wells Brason II today. He's the president and CEO of Project Lazarus, which is a community-based opioid poisoning prevention model that also presents responsible pain management and promotes substance use treatment and support services. It's based in North Carolina. It was started in Wilkes County, just across the border. And at this point, Project Lazarus is national, and it's also being done on a military basis. We're just talking. We think that it's probably also international, in places like Canada, and it's probably been replicated to some extent in the UK as well. Mr. Brason is a member of the National Association of Drug Diversion Investigators, APHA, NCPHA, North Carolina Public Health Association, and he serves on the advisory board for the North Carolina Controlled Substances Reporting System, which is their PDMP. He served on the FDA scientific workshop committees for the role of Naloxone in opioid overdose fatality prevention and assessment, and assessment of analgesic treatment of chronic pain. And he co-chaired the expert committee for the publication of the SAMHSA Opioid Overdose Prevention Toolkit. These are national, state, and then regional and then national level committees that are helping to lend credibility to this concept of the use of naloxone for overdose prevention, and then also the larger prevention programming associated with Project Lazarus. He helped create the ASTO, the Association of State and Territorial Health Officers, the ASTO strategic map for reducing overdoses in the U.S., and he also received the Robert Wood Johnson Foundation Community Health Leader Award in 2012. So we're privileged to have Mr. Brason here today to educate us about the role of naloxone in overdose prevention. And thank you so much for joining us on this cold but beautiful Friday.
Nice drive today, so.
All right.
Except for the tractor trailer on 321. But anyway, be a nice drive back. But no, I appreciate you being here and the opportunity. And I'm going to share some about the model and some about naloxone. And try and squeeze an awful lot of information in a short amount of time, which is the usual. But as was mentioned, we want to prevent, we want to present, we want to promote. We want to make sure we have a balanced approach in what we're attempting to do. That if we're reaching those to reduce the poisonings, the sedation, the overdoses, we have to make sure that everybody's included in that, so that the person with pain can still receive care, receive the medication safely, securely. But those who have developed issues around substance use disorder and addiction with prescription medications, where's the safety net? Because if you cut off supply, that didn't change demand at all. We want to make sure we're just not pushing problems someplace else. I do have some disclosures. We've had a grant before from Purdue Pharma and Zogenix, and I've also consulted on a med guide for overdose with Purdue Pharma and Kaleo. And we'll be talking about naloxone, and the intranasal naloxone is an off-label device, not approved by the FDA, but readily used. Wilkes County, very rural, 69,000 folks. We have about 91 people per square mile. So some people say that's not rural, but it's not urban. But it's very large and spread out, and it's pretty much manual labor is what dominates the community. We developed as a nonprofit organization, first starting just in Wilkes as a task force to deal with the issue that I found in 2004. Once we started some work there, then other communities began to find out about us and asking us to come help them. even though I'd freely admit at that point we didn't no clue what we were doing. I mean, literally, we started with nothing, didn't know anything. Nobody could help us because nobody had any answers. And in 2004, when you called Washington and Raleigh, and it was, what are you talking about? They weren't aware of anything, yet we were. So that's how it began. But on the premise that we do believe that communities are responsible for their own health. You can legislate from Washington, from your state capitals and all that, but implementation happens here. How does that get done? And how does it get done well in order to bring about public health change? And I had never been involved in any kind of scenario with overdoses. My background was hospice and home health for the most part. And once I started to hear about overdose, I had the Hollywood mainframe. It's okay, overdose, heroin, Pulp Fiction, that was about it. Until I learned what it is, that it is an injury, that it is unintentional, it is a poisoning, and starting to then grab the data for that, which was not easy to begin with. Unfortunately, and I've learned this in a number of other states, data people don't talk to data people in different territorial groups within a state, and so it's very difficult for local communities to get what they need, in real time. We've eradicated that in North Carolina, but we still have a ways to go. So what I started to do was ask the question. I've got to look at, if somebody's telling me 30 people in Wilkes County died, who are the 30? I need some information and some background and these questions answered. Who, what, when, where, why, and how. Because if I have more of that information, I can not only do prevention, I can do intervention, and of course we can make sure we've got treatment and make sure that we don't increase the statistics. So as we did those studies, we found out we had patients die from misusing their medication. They had the right prescription, they had the right diagnosis, but they did something incorrect with their medication. Either had more pain, took more pills. Or we found some that unfortunately they were on the right pain medication, but the doc prescribing that didn't know that they were on the benzodiazepine. Because the patient didn't want to talk about that because of what people think about them, on being like that. So we had those kind of scenarios. And then another one was family and friends not taking medication to get high or divert. They simply were self-medicating with another family member's medication or friends. Skip the copay, not forget the ED visit, just helping themselves that, mom's got pain meds, Johnny has pain, Johnny takes mom's meds, Johnny does not see the light of day the next day. We've had those in our communities. And then, of course, now we're seeing a good amount of accidental ingestion. About the top level of our emergency department visits now are ages 1 to 4 due to an adverse event from medicine or drugs that they accidentally ingested. And when we look at the numbers of prescriptions in the country, that tells us why. There's that much available and sitting out. And then we have the recreational user. We had folks that, had no history of abuse or use, but, in Wilkes County to go out and, have a good time or relax. I think we could probably maybe 4 or 5 bars in the entire county. So it's not like you're going to hop out and go around town. Most of it's in the homes or in the backyards or gatherings like that. And unfortunately now it's gone beyond moonshine, alcohol, marijuana, and now somebody's got some pills in their pocket. And they're offering and they're saying, take this. This will help you relax. This will help you feel good. And we had those scenarios, unfortunately. And then we have had those with substance use disorder, disease of addiction, in and out of recovery and treatment. Yeah, I've worked directly with individuals. One woman with 16 pills a day. I had one with 25, and then I met another young lady who, admitted she's, was in recovery and treatment, but she was up to 45 pills a day. And it's you know enough that even if I took 5 of those, I probably wouldn't be alive. But that's how much goes into the tolerance changes and what's necessary. But with that kind of medication, you're always on the cliff of sedation and overdose. So we as a community said, well, how do we reach all of these individuals? Because this is everybody. We couldn't just find a single population and say, well, if we just kind of segment them and work with those people, which I hate, but that's usually the term. You're going to leave somebody out. So we decided that we needed to embrace the entire community, and that was the premise of what we were looking at doing. Because we've also learned over time from the CDC, you've probably seen this, that for every one overdose, we have 800 to 1,000 people that could be, because of the behaviors that are going on in their life, anywhere from getting into treatment or in the emergency department, or who are abusing or dependent. But then what about these 733 non-medical users? Those are the moms and dads and the aunts and the uncles and the brothers and sisters in our communities. How do you reach them because you can't police that, you can't legislate it. You've got to public health address it. Change perception, change behavior, change practice individually, within our community, so that all of them aren't at risk to become one of those statistics. And we work with communities a lot, and of course we've got to stop the deaths. Totally agree. But if that's all you go after, you're missing this, and you're not going to do what you need to do long term. So as we started with nothing, this is what we ended up with. And Wake Forest Medical School came in within 3 years, after about 3 years of when we really were moving with this, and evaluated it and showed us what we had done and best practice and change practices, and kind of, finally the first ones to label success, in what we were doing. But it helped us really put the picture together of what we had actually done, because it was totally on the fly. I mean, it was totally on the fly as to what we were doing and how we were doing it. Because we were trying to change the perception of people, and this is unfortunately what society is today. It's, and everybody knows what medicines do, and in our day, my day, I didn't know what they did, unless I had to have it, that was it, but that's changed. So we started with public awareness on that wheel. That's the center hub. In the beginning in Wilkes, 2004, I was aware. We got the health department more aware. The emergency department and law enforcement agreed that we have a problem because they were seeing it on the front lines. Went to the schools, went to the general public, went to the civic, went to the human service organizations, and they're going, what are you talking about? And we know just from experience, the public usually does not get involved in an issue unless they are personally affected. So we had to sort of bring awareness to the point where they could make a contact, where we could connect the dots in their life so that they could realize how they are personally affected and how this is, an issue within our community. So that's when we tried to get as much data as we could from the state, because I could tell them how much, globally, well, there's this many people in the United States dying. That resonates some, but when you start talking about, we lost a 14-year-old last year, so-and-so's dad died, so-and-so's brother died, that's where they start to make the connection. And then you've got their attention. So that's how we did it with the community sectors that we found that did not know anything, weren't even aware, because I would go and sit down and I'd talk to a local pastor. And I was the chaplain of the hospice too, so I was going to the ministerial meetings and I'd bring it up and they'd look at me like, why are you even talking about this? Why are you telling me about this? So that's when we realized we've got to answer some questions. Because we want to go beyond talking about the problem. So we started with one, why am I needed? What do I need to know, and what needs to be done? And that's what we started to answer for every sector or person that we could visualize within the community, so that we could answer that question personally for the parent, somebody like that, or for the schools, or for the faith community, or the domestic violence group, or the child abuse prevention group, other United Way folks. And now we've come up with about 30 of those fact sheets answering those questions for the different community sectors, so that they know what it is that they need to know, but then it gives them an action plan. Even if it's a parent that's just locking up their meds now at home that wasn't doing that before. That just helps them make that connection. And that's how we brought about, the coalition building. And now this is just some of the information that we can tell each one of our 100 counties in North Carolina. We can have a whole data slide set for every single county with a click of a button for every single county, and this is just some of those. Actually, I come up with about 30 slides, for them, showing them where they are, comparing them with other counties, comparing them with the state, with all of this information. And we finally had to pull that from various houses into one source, working with the Division of Public Health, our PDNP, Office of Chief Medical Examiner, our NC Detect, the Hospital Association, and everybody, to where we can bring this as real time as possible, so that, again, we know where we need to prevent, intervene, and of course, treat. With that. So with that center hub sort of driving everything, then we can start to work with the community that surrounds that. And community education, again, why am I needed? What do I need to know? And we came up with the tagline so that people could begin to understand prescription medications. You take it correctly, you store it securely, you dispose of it properly, and you never share. That is new. Because most people, when you talk about medication, they take it as needed, which is the worst thing you could tell a person in pain, is to take it as needed, because they're always chasing that pain, not taking it one day, taking more the next day, and so forth, and storing securely when most people have it right on the kitchen counter or the nightstand. And of course, disposing properly. In our town, it's no way. I bought it. I paid for it. I'm keeping it. Somebody else might need it. I might need it. I'm not getting rid of it. And freely sharing, that's our culture. We help, and that it just spills over into medication too with the behaviors of folks. So that's what we were looking at changing within the community through all the different community sectors, because we're trying to reach the individual. And we all know as an individual, everybody's biologically different. I cannot stand pain medication. I'll never forget the day, the first time I took cough medication with a little codeine in it. I was sick as could possibly be. I thought I was going to die, just from a little tiny bit. So I just declare I'm allergic to codeine. Scientifically, I don't know it, but I know what my reaction is. But other people, that it just lights them up tremendously the very first time they even have any kind of a morphine derivative medication in their system. And everybody's got a difference in psychological, social, and spiritual backgrounds. So how do we do that when we're trying to change an individual and everybody's different, that even in our own homes, did I, when I was a child, or did my children, or spouses, partners, do they do what you expect them to do 24/7, 100% of the time? No. Even when you live with somebody, it doesn't happen. So we realized if we want to really impress change and bring about change to the individual, let's change the village. So that it's repetitive and the message is heard, seen, and aware among anybody and everybody that has a touch of somebody within the population that we have in our communities. So that a 7th grader could hear the message at home, prescription medications. If it's yours, you keep it. If it's not, you don't take it. That's what I knew when I was growing up. And I use the word specifically prescription medications, not prescription drugs. To me, when I was growing up, medicine was for an ailment. Drugs were the heroin, the cocaine, and others. Now it's blended together, that it's all drugs, and I like to make a difference. That's just kind of a personal aspect of mine, but in order to change the village, that 7th grader could hear it at home, hear it at school, hear it among peers, hear it from their coaches, hear it from their youth group at church, hear it from their clubs, that in the message, again, prescription medications, if it's not yours and you take it, you could die. I mean, that's bottom line. That's the reality of the situation, and in our focus groups and working with the teens in our high schools, that's what they want to hear. They said, just tell us the reality and we can make sound decisions with that. Don't fluff it, don't cover it, just let us know. And unfortunately, we've had some students who did overdose, and that, unfortunately, the fear factor does create some, change of behavior, but not enough. So we work with that, and an example I give, I never thought once of going into my parents' medicine cabinet. Now, when I was younger, it was not a yes or no decision. It was, I never even thought about it. I mentioned that to my brother, who's 6 years younger, and he goes, but I did. And I just looked at him and said, you what? When he was a teenager, he and one of my sisters, both 5 and 6 years younger, actually went into my parents' medicine cabinet, knew what was in there, and knew what it would do, and took it as teenagers. When I never even thought about it. So I'm thinking, wait a minute. Same house, same parents, pretty much the same environment. What happened in 5 or 6 years where I didn't even know, and they did, and went about and put an action to it? Well, somebody in the village. Somebody influenced them with that knowledge and awareness and possibly the behavior. So I just look at it, reversing that and say, okay, let's change it. If the village can do a negative, we can make sure the village does a positive. And that's the premise of Project Lazarus in doing that. So we began to work with our prescribing community, and I think we all are probably aware that most medical schools, it's about 9 hours of pain management that you get as far as education. Nowhere nearly enough. So we helped by creating a toolkit on managing pain, on appropriate prescribing, responsible prescribing, appropriate behavioral health, substance use, and mental health assessments, and giving our prescribing community that if you find a problematic patient, here's where you can hand them off to. Here's where you can refer them to. Most of the time previous to that, it was you found a problem, you weren't going to prescribe anymore, and you would just simply tell them, I'm sorry, I can't serve you anymore, I'm firing you from my practice. All that does is push the problem somewhere else. So we started to give the answers to the prescriber. Why am I needed and what do I need to do? Helping them with that, and we did the same with the emergency department. That toolkit is, it's all over North Carolina. We made sure it's been placed everywhere, taught everywhere, lunch and learn, CMEs, and everything. And I know it's being replicated in many other places. And this is just some of the things that are in there: opioids in the management of pain, assessment and management, patient treatment records, opioid overdose prevention, all of this. And we even started a Medicaid pharmacy lock-in program, one doc, one pharmacy. That's where you get your controlled substance. And all of those things play a part and work with that. And we did it mainly by lunch and learns. This does some, that gets it done. That's what we learned. That you could do the CMEs. You could, well, here's your toolkit. Take this and it'll help you with best practice around pain and prescribing opioids, and you would find it getting dust on the shelf. But when we walked in with the Subway sandwich and sat down with the entire office staff and went through it, the reasons why, this is what's happening in our local community, this is what we believe you can do with your pill counts and your urine screens and the PDMP, that's where we got buy-in. And that's where it began to make changes within the medical community around our communities. So case management was part of that. We dovetail the infrastructure of our Medicaid system with case management. So they have a chronic pain initiative reaching those patients in Medicaid that reach a threshold of opioids. Chronic pain management, looking at just their prescribing, their physician, and their environment, and helping them with that and keeping them safe. It improves the PCP efficacy. All of these things develop a reproducible, comprehensive approach to chronic pain management, and getting that within all of the networks. And with one of the grants that we received, they've done 40 CMEs around the state just on this. And at the same time, it's reinforced locally through the care managers and the chronic pain coordinators through the Medicaid network, so that you're reinforcing and bringing the message and getting it, implemented within those practices. Because this is what we show. If they're just looking at this, we're going to have problems. And so we help them looking at, assess and look at substance use and mental health, along with the chronic pain and the environment that medication is going into. Because Johnny could have the right diagnosis and need that medication, those 3 a days for 30 days, but what environment are those 90 pills going into? What's it like at home? Well, Dad's been an alcoholic on and off for years. Mom's been in therapy for medication issues, or Brother Johnny, or whomever. So we have to look at all of those, within our communities. And of course, if you're in the military, then you've got to add TBI and PTSD to these circles. It makes it even more difficult, but it has to be done. So the controlled substance reporting system, you're aware of those. I'm not going to go through all that. We did a study early on very quickly with prescribers, and some knew about it, some didn't know about it. Obviously now some states mandate it. We still do not mandate it. We don't want to. We'd rather build it as best practice, and we're about a 50% mark of those signed up in the entire state for prescribers and pharmacists. But what we found was most of them looked for clues. Patients who request early refills, patients whose prescription profile suggests. In other words, they're looking for that drug-seeking behavior. Now, we know with some it can be obvious. Others, you wouldn't even know for anything. So we kind of say, well, this is what you think, but what you need to do is just do it for everybody. Use the PMP no matter what you're doing, so that you can find the right information for the safety of that individual. We did the same for pharmacists, and we found the same thing. They looked for clues that were going on. And again, our premise is just do it. If you have any kind of an inkling or any kind of an intuition that there might be an issue, when in doubt, don't. Make sure that you check it out and do not have those prescriptions cross that counter until you know for sure. But what we found was, this was for the pharmacist, have you ever used information from the CSRs when you called a prescriber and concerns about a patient's prescription? Out of the 500, 404 said yes. And the next question, obviously, is, well, then what did you do? Well, 320 of those says, did the prescriber change the prescription? Yes. So if we get the communication and the information going between pharmacy and prescriber and patient, changes will be made. And then that many more individuals are safer. Now, what those changes are, I don't know. It could have been a lower dose. It could have been another med. It could have been not written at all. All of those are factors. But again, we know if we get everybody on the same page, we get people working together and change happens. We also had to do that in our emergency department. It was well known as the place you could go and you would get something. And of course, in 2004, we didn't have an all-night pharmacy, which meant on a Friday night at 11 o'clock, same faces, same people, same issue, same problem, because they knew they were going to walk out with something. So what we did, we started out as a guideline in 2006. Then in 2007 and 2008, it got adopted as administrative policy. We hired a case manager to work in the emergency department to work with the high utilizers, get them referred to where they need to get a continuum of care, not the emergency department. Frequent flyers that are there to try and manage chronic pain. The decision was we're going to give them a non-narcotic and get them referred to a specialist, a PCP, a dentist, wherever and whoever needs to address that pain outside of the emergency department. That if they're there for the wrong reasons, they'll stop coming because they're not getting the narcotic that they're after. But if they're there for the right reasons, they'll follow through with the referral for the most part. No more refills allowed out of the emergency department whatsoever. If it is warranted that a prescription needs to be written, that the physician in the emergency department must check the controlled substance reporting system and document that, and no more 30 days. 10 to 12 tablets, that's it. And I can tell you we've got whole hospital systems adopting this whole policy. And we've shown hospitals for the first 6 to 9 months, you're going to get hit. You're going to have complaints. You're going to have satisfaction score issues. But by the end of the year in Wilkes, all of that reversed itself. And it stopped the problem. So we have Novant hospital system, we have Vidon hospital system, Carolina Medical in a number of their facilities have implemented it because economically they learned it doesn't cause an issue. You just have to deal with the problematic patients on the front end because at the end of the year, Wilkes' satisfaction scores were better and the revenue was higher with less visits. It was the right people getting the right care for the right reason. So all of that we've shown continues to work. So we created a toolkit for that too. So again, so that it can be replicated by whomever, anywhere. And the ED toolkit has all of that in that and different forms and assessments. But one of the things we made sure that we did, that if a problematic individual shows up at the emergency department, whether it's a dental issue, whether it is drug seeking, whether it's a withdrawal, maybe it's an overdose, whatever it is, that emergency knows specifically who to call and who to hand that person off to or get into that emergency department at the time of crisis. And our behavioral health organization, they have a crisis intervention team. Their record now is within 1 hour, 24/7, they will be in that emergency room for any crisis for mental health, mental illness, and substance use issues. So that at least the person in the family has the right information to make the right decision of where they can go for care. Whether it's detox, medication-assisted treatment, counseling, residential, or primary care physician, or pain specialist, whatever that is, or the dental clinic. And, I know you're doing a study on the take-backs, and of course, we've done a number of those. We've got those permanent drop boxes. We've put in about 150 and throughout the entire state. And, of course, the DEA now allows pharmacies themselves to take it back. We're placing our first one in a Wilkes County pharmacy this week. So we'll have law enforcement and the pharmacy having those drop boxes. We know that there's some pharmaceutical industry that you can actually get these free now with a prescription if you ask, and the information is given out with that. Personal lock boxes in the home, our coalitions make sure that they're readily available at a very low price. Is this the end-all, be-all? No, but it is a component. But you know what it does? It raises awareness and education in the community so that people think of the safety factor of medication the same way they think of a seatbelt. There was a day where we didn't have them. But now what's the first thing most of us do in the car without even thinking about it? And what I want is nobody thinking about it anymore, that when they're done with their meds and they see that vial sitting there, I need to take that back to the pharmacy and get rid of it. Or wherever. A public health change in the practices. That's what we sort of drive with that as best we can. And of course, continuing to give our people with pain support. Through our Medicaid and through others in our local communities, getting Y programs to develop exercise for those with chronic pain. They do need support. They do need to be aware because we found them dying. Because they couldn't manage on their own with their own chronic pain issues. They were using just meds and they would just take more. So we want to support them and give them education and look at all the alternatives that can be done to and either enhance what medication is doing or possibly eliminate it, depending upon, lifestyle. And we know in our county, we don't have the healthiest people, all right? We just don't. We don't have healthy lifestyles. We don't have wellness and nutrition. We have an obesity problem. We have all sorts of issues that are going on. And all of this compounds it, with the chronic pain, problems. And then, of course, Naloxone. I'd never heard of it before. It took me long enough to even pronounce it. But when I did learn what it did, I asked one question: who's got it? And of course, the answer was EMS and the emergency department. And that's great, but in Wilkes County, the people that died never made it that far. EMS didn't get there in time. And it's much like many of your counties here. It can take you an hour to get from one end of Wilkes to the other. There's only one straight road, and that's 421 running through the center. All the rest are all over the place. So it's difficult to get to individuals that need it. And most of you are fully aware that it comes in the injectable format, or IV. And we learned, again, I learned early on, and even if I was given one, and I've never injected anybody in my life. So I'm going to have an issue if I had to do it, even after training. Though some can readily do it. We know with the heroin using population, it's a no-brainer. They're used to that. So I learned about the pre-filled syringe with the atomizer. And this now has become one of the more popular ones being utilized. And this is what we put together in our kit to provide to our residents who are at risk in Wilkes. 2 doses. In our kit, we buy 2 atomizers. We provide a DVD and a booklet in English and Spanish on signs and symptoms and how to use it and so forth. But pharmacies don't carry kits. I get a call from a pharmacist every single day. I got this prescription for Naloxone, and they said to get a kit. What's a kit? It's just, it's not on a formulary, and we know the atomizer doesn't have an NDC code, so it's not readily available. So somebody else has to sort of put things together to do that. And of course, the FDA realized that because we've been hounding them for a while, and they did approve the new auto injector last year. Are you all familiar with this? So I don't have to go through. It talks.
You might want to.
Yeah, this is the one that talks.
This trainer contains no needle or drug. To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete.
Life saved. Anybody can do it. And when the FDA, and the study was going on, they did give it to kids with no training, no instruction. Here, can you do this? And they did it. So this is rapidly becoming, it's the #1 formulary on the Department of Defense now. That an active duty soldier on an on-base pharmacy can get this for $0. It is the #1 on the formulary for the Veterans Administration, and it is now in their mail program so that they can actually mail it to a patient. And Medicaid, Medicare, and others are picking it up, quickly, but in my eyes, not quick enough. But essentially, intranasal is not approved by the FDA. Auto-injector is.
Do you know what their cost is?
If you were paying cash, it's like an EpiPen, you're going to pay $400 to $500. If 500, yes. If you're going to, and each kit comes with 2 and a trainer. If you have insurance, it's about $28, and it's good for 2 years.
Of course, a lot of our drug-using population
doesn't
have insurance.
Right. And but the company I've been on a work group with the Clinton Foundation because they've been trying to figure out how can we get naloxone more readily available at a cheap price. So the company has collaborated with them, and they have now developed a program for law enforcement, nonprofits, free clinics, fire folks, first responders, to where they can get this at the lowest possible federal allowable rate. And it's just going to be a matter of applying and getting it, And they've also had a donation program, and I just got 500 kits delivered this week, so that now we can, my sheriff's office is going to have one, our health department's going to have them. I'm sending 40 over to our Indian reservation because they've been using our kits, and I said, let's just try these, and I want to see what the response is, because there's no education with this, and it's good for 2 years because it's all self-instructing, not destructing, self-instructing. Yes.
Is there any freezing or any supply side?
With any of this, there is. Yeah. But in the studies that I've seen, this is more tolerant to heat and more tolerant to cold than anything else.
And resistant to sunlight and so forth.
Yeah. And when I talk with sheriffs, some are hesitant about this. We've had issues where EMS says it's our job. I said, well, it is, but you're not there first. My local guy in the pickup truck, who's the first responder with his radio on 24/7, is going to be there first in our county, and that's the person that needs to have it, and we're going to make sure that they do. And our state law allows that. And our state law now allows for if mom has son Johnny who has an issue, mom can go to the prescriber and say, I need a prescription for naloxone. That prescriber can write it to her and she can take it home and Johnny doesn't even know. But mom's got peace of mind because she has an antidote in the home. And of course now we have standing orders and so forth. And now Pennsylvania, Michigan, West Virginia's about to pass theirs. Their governor vetoed the first one, but just made some minor changes. And of course, the Good Sam law with that, we help states now do that. I've been in a number of state houses lately because it's a hot topic with the Governors Association now. So everybody's trying to get, up to speed with that. But we introduced this in the context of our whole program. And I can tell you in Virginia, they don't have a whole program. They've just tried to introduce this and they've had some pushback. But when I introduced this in the whole program in the context with the right understanding, I didn't get any pushback at all. And when I went to our medical board in 2007 and asked the question, why can't people have this in their home? The president of the medical board said, good question. And we had a public hearing with them. And I'm talking lawyers and everything. I didn't know I was walking into that scenario, but thankfully, I can talk. But anyway, they were the first medical board in the country to actually come out with a position statement saying best practice is providing naloxone and supporting those programs to those individuals who are at risk for an overdose. Because they saw the reality, even in their own practices, of the issue and the dangers because of what we could show. And of course, now the military is doing it through our Operation Opioid Safe at Fort Bragg. And we have a meeting March 18th. And we're pretty much going to have some pain med docs from about every base on the eastern seaboard at Walter Reed and present our pain program that we instituted at Fort Bragg, including naloxone. So they want every base doing the same thing, and that's down from MedCom. So it's follow orders. You get to do this, which is great. We've been after that, for a number of years. And just one sidebar on that. The first year we started at Fort Bragg, they were losing 15 soldiers out of 400 in their Warrior Transition Brigade to overdose. Not suicide, overdose. You got opioids, you have pain. These are the guys and gals jumping out of airplanes, and you got TBI, you got PTSD. All of those factors were playing a part. After 1 year, it was 1 out of 400. Wow. Because we intervened, provided education. I can't even tell you if naloxone was actually used, but everybody was educated and aware, including the soldier's family, or their barracks sergeant, whomever, so that they knew this person's on this medication, these are the risks and the benefits, understand what could happen, keep an eye out, and make sure that they're doing it correctly and not chasing their pain all the time in all those avenues. So that's why MedCom wants to do it on a greater basis. You know what it does. It kicks the heroin, the methadone, and the opioid off the brain receptor and wakes somebody up. That's what we want. I can't treat them if they die. I can help them if they're alive. And that's what we're after. And this is what I show the general public so they can grasp what it does. Because there's a lot of myths out there. Well, if they have that, aren't they going to take more? Is it going to enable them to do more drugs? Not true. Studies have shown that. It helps people get into treatment more often than not. Our medical board has approved it, the AMA, National Association of Drug Diversion Investigators, ASAM, the American Society of Addiction Medicine. They have a public policy statement that they put out September 11th. ONDCP, SAMHSA, College of Emergency Physicians, they're all saying it should be available, it should be prescribed, and it should be made available to whomever's at risk, whatever the cause, whatever the reason. And so that's why the government now is trying to push it even more. We did create the Sansa Toolkit a number of years. That's a whole other story. Boy, did I learn how government works and doesn't work with that one. But it came out and they made some adjustments last year when this got approved. See, in the initial one on overdose prevention, they could talk about naloxone. They could not talk about intranasal because it's not FDA approved. And you're not going to have one government agency superseding another one. So the politics and so forth is that they could talk about naloxone, but they couldn't talk about what administration. Now they can. So now they updated it and said this is what the FDA has approved. So this is what they're suggesting because of that. Now there are 2 nasal studies going on right now in the FDA from 2 different companies. So that there could be within the year 2 other single nasal devices approved by the FDA. We'll see about that. They're doing those studies right now. Who's at risk? Somebody who's smoking, heavy smoking, COPD, emphysema, asthma, sleep apnea, renal dysfunction, other prescriptions that they're taking, alcohol use, methadone for the first time, methadone treatment, buprenorphine treatment. Every person who is enrolled in our medication-assisted treatment facility in Wilkes County, whether it's methadone or buprenorphine, gets education on overdose and they leave with a kit. Everybody. And Maryland has now mandated that among their opiate treatment programs, not for everybody, but whoever the opiate treatment program sort of believes that is at risk. They can self-determine who that may be, but they have to provide the naloxone to that individual and the education. We're going to be seeing more of that.
So Jana Burson?
Jana's with us.
Yeah.
Yeah. She's with us. She lives in Wilkes now. Yeah. But, Maryland and others, and I know the state of North Carolina wants to actually make it mandatory for all opiate treatment programs. Just not there yet, but we'll get there. So these are, this is what we provide to the prescribing community, the general community, so that everybody's aware, and of course the pre-release programs for those being released from jail or prison. At least in North Carolina, they are 12% more likely to overdose than the general public. They were doing the 80 oxycodone the day they got caught, and they've been in for a week. Their system is cleared. What's going to happen? They're going to go home and take the 80 and overdose. If they know that, maybe they won't. So that's why we want to get the education, and possibly when they walk out of the jail or the prison, guess what? Here you go. You're walking into the environment that you came from. Even if you don't use, you've got friends who are. And that's our story in Wilkes. If somebody goes to detox in Wilkes 5 or 6 days and they're released, where's that person going after release? Same home, same family, same environment, same issues. We're a rural county. You can't move to another city in our county because there isn't one. We don't have one city in our county. They're all towns. And you can't even move across town because everybody knows everybody. You can't change your life staying there without help, support, and assistance to do that. So the community has to respond. So we drive it the same way. Naloxone, the village. Everybody needs to know. In every context, they need to know about it and know that it's readily available. Carry it, have it, and make sure that it's there. In North Carolina right now, it's law, mandated. Epinephrine has to be in every single school by law. West Virginia, I think, has done the same thing. We're now talking about mandating naloxone being in every single school in North Carolina. I know West Virginia is putting forth a bill just for that this year to make sure. I've got one school system that wants it on every bus because they know kids are using, and they know the increase of heroin is making matters worse. And it is the younger population that's using the heroin. So it's affecting the younger people more than than prescription medications. Those that are overdosing are around 40 to 45, mostly male. So we're integrating naloxone into the community. And how we're doing that is through community education. Awareness brings about acceptance and availability, destroying the myths, everybody understanding signs and symptoms, how to talk to your doctor, third-party prescribing being available, provider education. We bring it to them through the opioid overdose toolkits, patient and family education, co-prescribing, third-party prescribing, dealing with it with pain management, case management, mental health agencies, making sure that perhaps the psychiatrist who's in charge of the mental health organization can write prescriptions for naloxone. Why not? If they've got somebody who's there for substance use, counseling, and treatment, should be done. Hospital emergency departments. There's your perfect opportunity to sit down with family or person and say, here, just in case you've had an issue here. And, I get a little stirred up when, I find out that in Wilkes County we had one young man who overdosed, was rescued, brought to the emergency department. 3 weeks later, died from an overdose. That doesn't need to happen. Now, I don't know what was offered, what was done, or what gap might have been there, or maybe he totally refused. But there again, we need to have intervention in order to bring about change and save lives. And of course, diversion control, making sure law enforcement have it, schools, prisons, jails. It just needs to be there like AEDs are there, around for everybody. Harm reduction, making sure the using population does have access to it. And in our focus groups with them, it's like they don't want to ever have to have it done to them. They just like it when it is available. And needle exchange program in Pittsburgh, among the heroin using populations, they have some individuals that they call their mother. And if somebody is perhaps overdosing, they know that the mother usually has naloxone. So they know who to call and who to go to in order to save somebody if it's not readily available. Again, it saves lives. And then, of course, addiction treatment. All treatment facilities should be talking about it and making it available. We're about to do a pilot in West Virginia. They have 51 daily reporting centers for drug courts. The individuals that are in drug court must report to these daily to these centers. We're going to start with 5 centers, and every single individual is going to be educated and provided naloxone, with the plan that all 51 would provide it to everybody who's in drug court in the state of West Virginia. We know 2 things will happen. One, it'll bring about education and awareness, but it'll put the antidote into the environment where it needs to be. So those are things that we're now starting to do. And, of course, the military and tribal groups. I'm about to do a webinar for Indian Health Services because they want every reservation to know what our model is and the pain care and the availability of naloxone. And the reservations can get it under the 340B program or the VA mail program. So it's all at a reduced price. Standing orders, approved naloxone helps acceptability. It works, and we're thankful that we've been helped to be a driver at the national level to make it more available. Sansa might get $12 million this year for naloxone in a program. But at least in the current budget that's being presented, there's $99 million in there for increased treatment, naloxone, and other components. CDC's sort of slotted to get $50 million of that just for PDMP work. That's okay, but I'd rather see more towards the treatment end of things so that we can, bring about changes there. But we'll see. So naloxone, the conversation. When I talk with docs, they want, well, how do I talk about it? If I'm giving somebody oxycodone because of legitimate pain that they're having, how do I have the conversation at the same time that it could kill them? That's not an easy conversation. The most requested question I have at a CME from docs is, give me a script. Just give me something that I can talk and how I can talk it, and I'll gladly do it. So, we're working on providing that. And the same thing with treatment. If you're talking about somebody being abstinent, how do you talk to them about relapse? And making it available. It can be done, and it is being done. And part of that is we know where you're coming from, we know where you've been, and we know you have friends, and they're probably still using. We just want this out there, with you and for them. So that's another way that we drive it. And this was a Jana Burson story. One of our first rescues in Wilkes County. A young man got into treatment for methadone, got his kit. 3-4 months into that, one night he calls the clinic and says, my sister's overdosing in my apartment. What do I do? They said, hang up, call 911, get your naloxone. He did, sprayed it in her nose and saved her life. And 4 days later, guess where she was? Same treatment facility, getting the same help that he had gotten. It works. I had a mother save it to her own 2-year-old because the 2-year-old ingested mom's medication. I've had friends save a friend. I mean, it's just one story after another, and it works. I mean, that's the bottom line. It just needs to be, readily available to anybody for any reason. And when the FDA approved this, they wrote it so that there doesn't have to be a diagnosis to write this prescription. It can be written to anybody for any reason. All you have to do is ask, and you can get a prescription for it and have a pharmacy fill it. Most pharmacies don't carry any of this because most of them are not familiar with it. I was just in one town, and the pharmacist who was also the store manager for that pharmacy looked at me and said after I had talked, he said, I never even heard of this before. So I mean, that's the kind of ground that we need to cover in order to make about and bring about, change for individuals, which again tells us that we move this into a public health model. MMWR from CDC back a number of years ago showed that from 1996 to 2010, over 10,000 people have been saved through various programs. Now, they did print this, and we know that most of that is still anecdotal, coming back to the needle exchange programs and other programs, but it works, and it's proven over and over again. I know you've talked about, you just showed me the article beforehand. This is the one article that, with Alex Wally and others, that the study that they showed, death rates from opioid overdose were reduced in communities where overdose education and naloxone distribution was implemented compared with not implemented. So again, if the community has it, deaths go down. One study, I should have put it up here, where naloxone was readily available, heroin use went down. It just, again, the whole concept of the awareness and education and bringing about change. Pain medicine with a VA study, risk factors for serious prescription opioid-related toxicity. Again, they say additional measures to reduce opioid-related morbidity, co-prescribing naloxone. And we're now getting more of the VAs, to do that. And the VAs now are reporting into our prescription drug monitoring programs. So all of that is going to help, the active duty soldiers. Now that the VA in North Carolina is downloading into the state PDMP, the #1 prescriber in the state of North Carolina for opioids is the VA. Now we know that because we now have that data and
We think
information.
that'll happen here too.
So where do we need to have more intervention? Of course, the VA. And we're working on that. And the Department of Defense. Save a Life, naloxone, the overdose antidote. The public needs to know about it. We're about to do a trifold, kind of brochure that we can put out anywhere just on naloxone so people can begin to understand what it is, how it can be administered, and why. And get rid of any kind of stigma, regarding that. And if you get these slides, then there's more, on the internet and more being done every day, regarding that. And I can tell you this much, keep your eye on the Federal Register. There will be another hearing coming up this summer sometime on naloxone. So keep your eyes on that. The dates are set, but it has not been put out publicly yet, but keep an eye out. And once I can publicly say, then I'll make sure that, everybody's aware. But that'll be a 2-day event in Washington area. So what happened in Wilkes? 69% drop in overdoses. In 2007, we were the 3rd worst county in the United States. All counties, all states, we were the 3rd worst. We dropped 69. If you spread it out over a number of years, it's more than 50% and remaining as such. Now, we're still having overdoses. And I'm still doing that who, what, where, when, how, and why. We have not had a pain patient make a mistake with medications in 4 years, based on medical examiner reports. We have had one individual who unfortunately was the 14-year-old that got into Aunt's medication, or Aunt got into the medication and gave it to the 14-year-old. All the rest have a history of substance use based on medical examiner reports. And we've trained our medical examiners to do an investigation. Look at the PDMP, talk to the family, what was the history, and we can get eyes on those. And the medications, the prescription opioids and the benzos, they're not coming from Wilkes. And that's a testimony from our sheriff. When they've made their arrests and then done their investigations, nobody's scamming the medical community in Wilkes. Nobody's scamming the emergency department. They have to find sources outside of Wilkes, and they're bringing it back. Now, I looked at 30 individuals from the past few years, and I looked at their data according to treatment admissions into our medication-assisted treatment program and so forth. 3 out of the 30 had at one point in time in their life attempted to have treatment. Where are the other 27 that never, according to the data records, ever entered into treatment? That meant we were still missing somebody. We were still having gaps in our community to at least get to everybody that we possibly can. So again, those kind of research and studies help us where we need to do the interventions. Our substance use visits are down. Diversion tips to law enforcement have increased. We did not start in 2004, 5, and 6. We had no medication-assisted treatment. And trust me, my community did not want it. That was a horrible subject to even brought up, but I brought it up anyway. Methadone was the 4-letter word. I mean, it was nasty. Very nasty. But we were able to introduce buprenorphine in a clinic setting. And then we went on a 2-year campaign, and then we're able to introduce methadone. We now have between 400 and 500 individuals being daily dosed and treated on either methadone or buprenorphine in Wilkes County. And acceptable. March of last year, the headline of the local newspaper across the top of the page, methadone clinic reduces RX deaths. And then they had a whole article on the methadone clinic. Because one of our commissioners said, oh, those methadone clinics, they're just a scam. So the reporter called me. We educated him. So he knew what to put, and he put it out there. And that's Jana, and her group. I've got multiple family generations in treatment at the same time. I have that's a grandparent, a parent, and a child all in treatment at the same time. That's the generational issues we've had in our community. Sad as that is, I'm hoping now maybe the 4th generation won't have the issue. We have to drive that at the local community to get that done. In 2011 and 12, we had 7.4 substance use incidences among 1,000 students. 2012 and 13, 4.9. 2013, 14, 3.4. Something's happening. Something's beginning to work. That methadone clinic, when I had that meeting, I actually thought I'd be tarred and feathered and run out of town for even bringing it up. Our churches came to us and asked how they could support those individuals who were receiving treatment. Because guess what? They found out they were in their churches. And they saw and experienced the changes in their life to where now they're coming to church, they're helping taking care of their family, they're financially responsible, they're going to work, yet they're receiving a drug. So guess what? We now have churches financially supporting daily dosing for individuals from their congregations to get treatment. That's huge. From a rural, southern community conservative, that is huge. I couldn't have asked for more than that, but it happened. I didn't go to them, they came to us. So those are the things that we love to see. Yet we didn't have to change prescribing levels. We still are, 1.5% to 2% above the state average. We have a population that needs it. What's a dairy farmer got to do tomorrow morning? They have to get up and milk the cows. They can't go down to Charlotte and get invasive treatment or whatever else. They've just got to keep going. And we know with chronic pain management, that prescription is going to keep them going and hopefully safely with doing that. We've had enough communities now that we've done some studies, and where those communities adopted what we've been doing in their health department or embedded within that community, those communities have a 23% lower substance use visit rate to their emergency departments. Coalition with a public health approach does make a difference. And now we've also learned that we have a 2.7-fold increase in success in getting something established if we invest in leadership. So we've moved into a train-the-trainer kind of mode to where now we're training community champions. I'll be in Michigan next week. I'll be in Pennsylvania again the week after that. I've been in Florida. I've been in Maine. I've been, training people on what can be done and how it can be done so that they can then mobilize their communities to do the same thing. So now we have whole states looking at what we're doing in North Carolina, which is great. It's fantastic. But we're starting from scratch with some of those states, pulling the data together, getting the right people on board, but at least, the attention, the energy is there. That's us. Our website's about to be brand new as soon as I do some more writing and editing with more information to where the actual wheel will be on the front page and you can just mouse over it and click on that part that you want and it'll give you all the information that we can possibly gather for communities and others to help out with that. And I know that's an awful lot of information very, very quickly, but that's sort of it in a nutshell. I'm glad with the studies that you're doing here. I look forward to those papers and hearing and seeing what that's about. But I know Tennessee's got some work to do. I've talked to some, your health commissioner, John Dreisner, and Doug Varney, and we've talked to them about, if we can get some money, we can help implement some of what we've done here. And we try and get money on our own. And when we go into states, it's like, we want to come in and we'll find our way, but we want your money to go into your community. And when I told West Virginia that, just give $20,000 per community, and they were like, well, that's a no-brainer. 55 counties, $20,000, it's just over $1 million in a state budget. That is nothing. Every state says the money's there, we just don't know what's being done with it. So they're looking at ways for that to be done. So we're thankful for that and just appreciate what you're all doing here, in Tennessee with your study. And I've worked with Sarah Melton for, a while now and others. So just thankful for that. Any questions?
Yeah. Well, first of all, I gotta say that was a fantastic talk, and I just really applaud what you're doing. I can tell, you can see passion in people, and that's what drives a lot of this, and that's just you're to be commended for your passion, your drive, and your innovations that you brought forward. So thank you for the work that you're doing, and the impact that's having is felt all over. So how is Tennessee State Department of Health and Mental Health, how are those folks responding to your questions about this? Because, it's in the state prescription for success. If you haven't seen it, I have a copy. And, Project Lazarus, or I guess Naloxone and other things are mentioned in that plan, although not with specifics. And so I've been kind of curious, like how could this be implemented on a grander scale, and sort of how can we help facilitate that? And
It can be done on a broader scale. It's not being done yet. Those are the suggestions, in that document of what needs to be done. But there's no central mobilizing to do that. I've had like Coffee County and Coffeeville and other places call me directly and say, "Can you come to us in our coalition?"
Yeah.
And which I don't mind doing. But after I hear from 1 or 2 or 3 counties, then I go to the state and say, this is what your people want.
Mm-hmm.
What infrastructure can we do this?
Mm-hmm.
So those are the kind of conversations I've had peripherally, not directly, with John Dreisner and others, but needs to happen. And we're having the same conversations in Kentucky.
Mm-hmm.
They've had Operation Unitas prevention and so forth, but you have to have prevention, intervention, and treatment.
Oh yeah.
Prevention's not used to the other two. So we that's how we look at doing it. So helping to drive it is getting back to that table to have those kind of discussions.
So in Tennessee, it's not unlike the CDC problem where CDC has injury control,
Right.
sort of an epi, right? But SAMHSA has prevention.
Right.
And sort of we have the same kind of artificial split here,
Mm-hmm.
where the Tennessee Department of Health really does epi.
Right.
And Tennessee Department of Mental Health and Substance Abuse Services does treatment and prevention.
Right.
And
Same
they
in North
do
Carolina.
a heck of a lot of treatment.
Yeah.
We haven't yet figured out how to unlock the data that you guys have unlocked as well. So that's something.
It's
really,
those same people in North Carolina that we had to unlock that with.
Yeah.
But we
Exactly.
all got together at the table. We have a state work group that now meets every 60 days, and that includes all of those individuals. So that's how we were able to get it done, and we used the issue to drive it. You're keeping that information from us, and it's not doing any good. And it's hurting and harming our communities that want to make a difference.
Yeah.
And that's sort of what drove that change. And Pennsylvania's got the same scenario. When I was just there recently, somebody snuck out of the Division of Health and snuck over to the drug and alcohol program and said, we just had an outbreak of synthetic marijuana in Reading, and we had like 6 people die. So the drug and alcohol program calls the DEA, and the DEA got involved, and within 3 days, where they were making that in the house, that was shut down. But the DPH person had to do it on the sly.
Right.
And they actually did get in trouble for sharing it. It's just like, wait a minute.
This is all health.
But that's just where it's been. But it can change. I think we've shown that. But it takes some effort and work. Now, one thing that can do it, and Vermont, Maryland, and a few other states, the governor has called a state of crisis on this issue. They can then mandate data be open and shared with this, and that, because of that emergency crisis mode that can happen. So that, I know we're looking at that in Pennsylvania to talk to, the governor just made the drug and alcohol commissioner a cabinet level position.
Right.
So now there's more access, and now if that crisis is called for, that's one of the elements we can say, now this needs to be done. Then authority has said you have to do it, and it just tears down the territory. That could happen in Tennessee too, if that's an issue.
I think we need greater urgency on that fix. We know that there's been some movement on the changes to the laws related to sharing the PDP data.
Mm-hmm.
That was fairly recent.
Right.
I'm not sure if the state FE working group is active in the data related to that, whether or not the data we're sharing pieces are moving at all. So in fact, it feels like they've kind of ground to a halt. So I think we have some work to do on kind of moving that along, helping those guys realize the urgency.
Yeah. Well, we now have a map of how it gets done. Yeah. And the DPH helps with a lot of that in North Carolina.
Is the intranasal kit available for
Yes.
prescription? What is its cost? Is it more reasonable?
Comparing these two is apples and oranges. Literally. That's like an injection of epinephrine is like nothing, but you go to an EpiPen and it's very expensive.
Right.
This is the same thing. Amphastar just doubled their price, so I can get this for $40, $39.99.
And who makes it?
Amphastar,
Ampha.
Amphastar. Hospira makes the Naloxone. and they're a North Carolina company. They're the only maker of naloxone in the country. They just got bought out by Pfizer. So we'll see what happens with that. Their prices have remained low because this is what they can provide. Amphastar provides this. But this is a separate off-label item that they raised. Teleflex has this. They raised their price to $5 something just for this, and you need 2. I can still get it for $3 1/4. So you're talking $43 for 1.
Versus $400.
Yeah, unless you have insurance, right? Yes. But then there's 2 of these, so you're talking about $100 a kit, because we have the booklet and the DVD, and I have an office where these are put together. When we get orders, and I can put all this together with the atomizers for $12. And then whoever needs to fill in the naloxone can fill in the naloxone, and then however that's paid for.
Do you take interns?
Yeah.
Okay.
That would be an incredible field experience. Is that what you're thinking?
Yeah, we can give somebody some experience, yes. Because we now have launched Lazarus Recovery Services. We have a program now through Robert Wood Johnson grant where we have peer specialists, state certified, and they are responding to those individuals having crisis in the emergency department, the referrals from the opiate treatment program, the detox center, and they're guiding them in life to get them back on their feet. They're not professional counselors. They're just somebody that has been successful in recovery, and they are like a peer advocate. And they will work with that individual to help get jobs, clothing, food, whatever, housing, just the aspects of life that brings about community support. And we have 1 male and 1 female. They're on board, being paid, and we got more referrals than we can handle. That quick, yes.
Fred, I apologize. I've got to go for an appointment with students, but maybe we should ask about partnering with the methadone clinic. Given their hesitation locally and some of the activities that are going on here, how you've seen that be successful in your community. And I'm talking about the sponsorship or ownership of the methadone clinic, as well as how you turned it into a positive in the community.
Yeah,
because we've had hesitation as well.
Yeah,
big time. And Jana Burson's actually written about our local problems with this.
I know that already. Yes.
Yeah.
Yes.
Yeah. Jana, if you guys haven't found it yet, Jana Burson's blog comes out like maybe once a week or so. I think it's usually on Mondays.
Yeah. But
she writes really well about things like harm reduction, things like medically assisted therapy, and just the opioid problem in general. She's a MD who is also a methadone prescriber. I guess she
medical director of the clinic.
Medical director of the clinic. That's right. Does she own the clinic?
No.
Okay.
No.
Is that in Wilkes County or is she?
That's in Wilkes County.
Yeah.
Mm-hmm. She when we were looking to introduce methadone buprenorphine, we vetted clinics. Mm-hmm. We went out and we interviewed clinics. We wanted the right one, that was community-oriented, counseling-oriented, group-oriented, an advocate for the person. Mm-hmm. And then we said, that you're the ones we want. And then we helped them establish a satellite with SAMHSA and all the oversight in Wilkes. And that was owned by 2 individuals. They sold out to CRC Health. And that's what Jana brought in. And she became part of that. And they've now been bought out by Acadia, which is more of a residential treatment, care national, for like $400 million or something or other, But out of that $99 million that the feds are now looking at appropriating, medication-assisted treatment increasing is in that budget. So we're hoping that will make its way through.
We have the heck out of some buprenorphine. We have it all over town. But we don't have any.
There's a good and bad and ugly with that too.
Yes,
Sure.
That's right.
Yeah.
I was wondering if you could speak to that. I mean, what advantage do you see of the methadone clinic setting over individual prescription buprenorphine?
Methadone works and buprenorphine works. To me, it should be readily available to whomever, and they have that choice, or it's determined that this is your best option. Our methadone clinic does methadone, does Subutex daily dosing, and then does some prescribing on the Suboxone Subzolve, on the 30-day supply, and have had successes, all around that. We have seen basically Suboxone clinics open up, and they're just running people through. It's a cash business, kind of scenario. We just had a practice open up in Wilkes, and I knew they were coming, and I had talked to them before, and they were going to do some pain management, and they were going to do Suboxone and so forth. And I said, well, that's all good, you know. Well, we've seen a good amount of prescriptions being written for opioids, and it's not Suboxone. They are writing prescriptions for Subutex, to the amount that our pharmacies conspired locally, and they have stopped filling prescriptions from that practice. They did that on their own because they're so aware of the issue and the problem, and they want to be in the forefront. I just found out about it. I didn't know that they had done that until just the other day when I met with one of the pharmacists, and they said, no, we have decided collectively that we're not going to fill those prescriptions. That doesn't mean they can't go out of county and do that.
Some of that's happened in this area. There have been some pharmacies that have resisted filling Suboxone.
Yeah. You know,
There's a lot of diversion of Suboxone.
Yeah.
And you know, it's justified in a way, by prescribers that if there's diversion of Suboxone, it's for people who are trying to bridge between
Right.
Their own Suboxone or trying to get to a place where they can get back into treatment. So that continues to be an issue related to how people perceive addiction. But at the same time, it's illegal, and we don't want to facilitate it.
Right, exactly. Yeah, it's like they're diverting Suboxone. Is that really a bad thing? But in some circumstances, yes.
Yes.
It is against the law. One of our approaches, especially in our rural communities, is to promote more of the buprenorphine, because we want the local primary docs to get certified and at least handle the 5 to 10 patients in your practice that may need it. Mm-hmm. Because medication-assisted treatment clinics cannot be in every single community. There isn't enough. Economically, it's just not going to work. They have to have volume in order to exist. And so that's how, and I'm working with AAAP, the psychiatry, addiction psychiatry group, so that we can now offer free trainings. Half online, half face-to-face, and get your certification. And of course, they go, I don't want to have a clinic. I don't want to. I said, you don't have to. But I guarantee you've got patients in your practice that this would benefit. So just add it to what you provide. You don't have to put a shingle out there.
It's been difficult to get providers to do that.
Yes. We're making some headway, but it is difficult, yes.
We were doing that through our family medicine residency here, but we were getting resistance from the nurses, from the front office staff, and from some of the other physicians in the office as well.
There's just a whole lot of preconceived notions about. Again, it's the addict is not desirable to have around. There's all kinds of issues related to this. It really has to do with people's failure to understand addiction as a chronic relapsing disease.
And my disappointment is we did that for 6 or 7 years, and I figured that over time, after exposure to these patients, that folks' prejudices would abate, and they didn't, which was really disappointing.
Yeah, that's an interprofessional health competency if you think about it. The ability to put yourself in the position of someone, irrespective of what you think of their, irrespective of what your background leads you to believe about their behavior.
Fred, I was wondering what a couple of the things I heard you say suggested maybe that pharmacy wasn't as on board as they could be. Is that?
Yes.
What opportunities do you see for pharmacy and pharmacists to get more involved in this?
Well, we actually put a pharmacist CE together so that we could visit with our pharmacy associations and provide a dinner in 2 hours just on this and what they could understand about forgery diversion techniques and that, because we got the SBI involved and the Board of Pharmacy involved. But a lot of it's knowing about naloxone. And that's why Rhode Island, New Mexico, I'm not sure what other state, now the pharmacists can directly dispense on their own naloxone. And we're working on that for North Carolina. So they're part of the front end, and we want them on board, but they have to have the information. And most don't. Even in Rhode Island, some of the people that help get that through, they would test different pharmacies and go in and say, hey, I'd like some naloxone, and the pharmacist knew nothing about it. So, it's that kind of scenario. It's I don't know where, the DEA approved drop boxes for medication now in pharmacies. We know that it's going to take the larger corporations probably a long time before that drills down to the local pharmacy. So we're going and talking to the mom and pops. And we've had immediate success.
we've been thinking about the same kind of concepts
Yeah.
here. There are certain things you can introduce in a mom and pop, or a local, even smaller chain than you can. You're going to have way more success there before you're going to have it at CVS and Walgreens.
Yeah, exactly. You know,
Unless CVS and Walgreens sees a lot of day and then mandate it, and all of a sudden the world is going to change.
Right, right. And of course, then they have to, well, I have to pay to get rid of this and all that. So guess what? The local sheriff agrees to, I'll go get it, and I'll just put it with the rest of our stuff that we have to get rid of anyway, and we get it done that way. That's integration in the community. And back to your question about buprenorphine, and I know the feds are going to be pushing more and more integrated behavioral health and primary care. That is where everything is going. And our CMS Innovations grant for our 16 Western counties I got with our Mountain AHEC and Project Lazarus, that's exactly what we did. AHEC was the one that would put in the social worker and stuff in the behavioral health in the practice, paid for by the grant, and then we would do the community piece. And we're just finishing up 3 years of that, and overall, from what I've seen, it's been successful. But not easy. Not easy because of those misunderstandings and all of that. And there was one community, that very small community, but word had gotten out that a methadone clinic was coming. The prescribing community was up in arms. So we convened a meeting at an Episcopal church on a Friday night. 35 doctors were there. This is a very rural community. That's about everybody. And they were all angry because they were all against us. Not in our community. And I had one young doc there. When I say young, he had to be under 40, which means pretty much out of school. But he says, I don't want those people sitting next to that grandmother in my waiting room. And I'm a pretty easygoing guy, but I just said, no, wait a minute. I said, you're talking about those people? I said, if this was Sunday morning and 150 people were sitting in this church, those people are right here.
I did the math, and a little less than 1% of your population in your county is on buprenorphine or methadone. So you're really talking about people that are all over in every walk of life.
Yeah, and that's horrible, but that's raised more awareness and acceptance of addiction and trying to deal with it, because it has reached populations where it was not as prevalent before. Where maybe it might have been just been alcohol, but now it's, we've got prominent people that have lost sons and daughters, and that again, until you're personally affected, you normally don't do what needs to be done, but, now we're getting more of that. Thank you very much.
Thank you.
Yeah, this is fantastic.